Very good morning, all. Today I will speak about the stridor. Stride is a nothing but high pitch, harsh sound when air passes through the obstructed airway because of turbulent. So whenever stridor is there, main thing differentiates is it inspiratory stridor, expiratory stridor, biphasic stridor. If you know pathophysiology, easily you can identify the etiology for the stridor. What is meant by inspiratory stridor? It means stridor there during the inspiration. So this is usually seen in the extrathoracic causes. What happens in extrathoracic areas? The pressure decrease in the inspiration. That's why causing of the more air rush. Whereas expiratory stridor usually seen in the intrathoracic causes. So we know that during expiration, intrathoracic airway pressure increases. It causes the collapse of the airways. It causing the stridor. So whenever stridor is there, we have to think for the three causes. If the stridor is there, we have to asking the history of is there any intubation required. We have to rule out the subglottic stenosis. Associated with hypotonia, sometimes some syndromes can cause stridor. Third one maybe laryngeal anaphylaxis. And I will discuss more about the one of the most benign condition, laryngomalacia. More than 80 to 85% routinely seen stridors are the laryngomalicious. So how will you identify this laryngomalacia? The stride usually present at the second or third week. Even though the anomaly is there since birth, the airway flow is not that much to create the stridor. That's why first 2 weeks child doesn't have any symptoms. The symptoms start the second week and third week. It reaches peak by 6 months. Then slowly decreased by 90%, 18 months, stridor will be disappear. How will you identify that? The stridor worsen during the infections or hesitations like crying, worsen during a supine position. Whereas stridor better when baby in the sleep or baby in the mother's shoulder or prone position. So when you suspect in this one, simple fiber optic laryngoscopy can sufficient to identify the laryngomalacia. But the symptoms are severe, moderate to severe obstructive symptoms, then require the bronchoscopy. The main treatment is the supportive treatment, usually associated with laryngopharyngeal reflex. For that, we have to give the PPS for the long duration. So again, it is a benefit and risk ratio. Long duration PPS can cause iron deficiency anemia, pneumonia, all these things. That's why clinician take a decision how many days you have to give the PPA. Very minute of cases, around 10 to 15 cases of laryngomalacia, they present with a failure to thrive, recurrent aspirations, recurrent admissions. They require surgery called soproglotoplasty. So that is a almost 90% recovery takes place. So the benign laryngomalacia always to be identified. Thank you.